Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ratan Jha sir. Sir is senior nephrologist and transplant physician at Care Hospital, Banjara Hills, Hyderabad. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is screening the high risk patient who needs early nephrology referrals. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, Sir.
Good evening, everyone. The topic that has been allotted has got a lot of importance in our day-to-day kind of practice. That is screening the high-risk patients who will need an early referral to a specialist to get the right advice and treatment to reduce the risk of disease progression. So when you talk about screening, we always have to understand what is the benefit of screening, what is the risk of screening for a patient who may have a chronic kidney disease. So benefits of screening is that it prevents complication and thereby it can prolong life of a good quality. But the risk of screening, that is unnecessary screening, is in the form of producing psychological stress that we see many times when people get genetic testing done to exclude other kind of disease like cancer risk or other many other kinds of diseases which are linked to gene. It produces a lot of psychological stress and for which we have no treatment. And then many times we see this PSA, that a prostatic specific antigen done as screening for carcinoma prostate, which may be misleading, and that's why it is no longer considered to be important tool unless it is focused to the patient. So when you talk about screening, the screening for all the physicians are of three types. One is called the kind of population-based screening or mass screening, where you're looking at the risks in the population, like hypertension risk, diabetes risk, kidney disease risk. So that is a population-based screening, which is simpler. Only few tests are there. The other type of screening that, as a physician, that we look at is screening the high-risk patient, where we will have high yield of getting the right patient that is there. And third type of screening for all the specialists is syndrome-based screening, so that we get the right kind of patient to give them the right advice to prevent complications like CRM, cardiorenal metabolic syndrome, or cardiorenal syndrome, or syndrome X. So that is a kind of syndromic way to pick up the patient to decide for screening. So in general, we talk about screening, which is a mass screening or screening the high risk population. But in the recent times, even the syndromic screening is being talked about in our nephrological practice. So when you talk about screening or mass screening the healthy population to target the kidney disease detection early, this means screening patients who are diabetic. So there's nothing called type 1 and type 2 diabetes. All patients have to be screened for kidney disease at appropriate intervals. Uh, Hypertension patients getting screened for kidney disease, especially when it is a resistant hypertension that is not getting easily controlled with 2 to 3 drugs. If there's a family history of kidney disease, this is also a target group to screen, like patient of polycystic kidney disease or Alport syndrome or any other kind of disease which runs in the family where patient is getting transplanted, multiple people getting transplanted in the family. These may be a kind of a situation where family history is important to screen the people who are looking healthy. A person who has suffered from some form of kidney injury or received dialysis in the past for some reason needs to be screened for development of chronic kidney disease, or a patient who is having repeated urinary tract infection, which is known to be associated with disease occurrence and progression. People who are above the age of 60 years with comorbidities like uh, diabetes, heart failure, obesity, osteoarthritis requiring drug therapy. So these are the age group where people have to be screened even if there's no overt diabetes or hypertension. Rheumatological disorders, particularly which where patients are prolonged analgesic, needs to be screened for kidney disease. Any patient, a person who has got a general checkup in the for a fever checkup where you find that patient urine is showing a proteinuria, hematuria, needs to be screened for kidney disease. And in children in the pediatric age group, when a child is not thriving well, that is, he's not having proper growth or proper kind of mental development or bone development or has a resistant decay, such patients should also be screened. So these are the target groups for screening in an apparently healthy looking patient who may not have kidney disease, but the risk factors are there. But so these are the screening that population that you talked about who are not having any symptoms. But symptoms of kidney disease, if that becomes a kind of target to screen, then it is too late because we know that symptoms of chronic kidney disease are usually seen when the patient has a GFR below 30, that is stage 4, or GFR below 15, that is stage 5. So symptoms are seen quite late, and we cannot go by symptoms to do screening. And that was the reason in our training times, people were getting the diagnosis only in the late stage of disease when the patient GFR is below 15 to 30. And the symptoms for which they used to come were all related to anemia in the form of fatigue, shortness of breath, not able to walk for a long distance, or because of the metabolic acidosis, they used to have some kind of uh, loss of appetite with protein energy wasting, sarcopenia, muscle wasting, weight loss, and occasionally acidotic dyspnea. Salt and water handling related symptoms that was seen in the earlier times when the diagnosis was delayed was in the form of edema in the legs, hypertension, and PND because of the reverse dipping of the blood pressure. And the toxin related kidney disease symptoms were related to skin symptoms in the form of pruritus, easy bruisability, bone symptoms of bone pain, back pain, CNS symptoms of not able to concentrate and occasional seizure, gonadal dysfunction in the form of infertility, and dyselectrolytemia related problem of hyponatremia, hyperkalemia, etc., which can give a symptom only in the late stage. So we should not wait for symptoms to come to screen a patient of kidney disease. That is a slide to just say that how symptoms are misleading and are seen quite late when the GFR is below 30. Because there is not time to screen, there is time to treat. So the screening tools which are recommended for checking a patient for the first time that he has kidney disease or no kidney disease is the estimated GFR, that is a kind of GFR which is based on either serum creatinine level and occasionally serum cystatin C level. So that gives an idea about how much is the kidney's filtration capacity. Normally, a kidney has a kind of GFR in adult around 100. Anything above 90 is considered to be normal. This GFR is usually raised in situation of pregnancy where the GFR could be as high as 150 ml per minute per 1.73 meters square. So eGFR is one of the criteria to say that kidney is good or not, and this is based on the formula, estimated GFR based on the formula, where cystatin C value as well as the creatinine value can be utilized besides the age. The other screening tool which is recommended is to look at the urine albumin creatinine ratio, and this is a tool which is much more applicable in a patient of diabetes and established kidney disease with proteinuria. In other situations, the urine examination in the form of complete urine examination to see that presence of RBCs, WBC, specific gravity, and crystals is a part of screening, etc. So urine examination either albuminuria check or a routine microscopy check to see the presence of RBC, RBC cast, and the WBC and the crystals. Serum creatinine and electrolytes are always a part of screening because based on that we decide whether what is the GFR. And renal ultrasound will be required in situation where some abnormality is picked up on these tests. So these are the only few tests which are supposed to be done when you're trying to screen the patient for making a diagnosis of kidney disease for the first time. And when we talk about eGFR, these are the two equations which is shown in the slide. That is based on the 2021 the CKD EPI equation. That is a kind of CKD means chronic kidney disease and EPI means kind of epidemiological equation that has been used by and recommended by National Kidney uh, Foundation. And this is a kind of equation where only serum creatinine and age has to be put into the this app, and you get and the gender has to be put in, and GFR automatically gets displayed. And in certain situations, we use cystatin C where the patient is malnourished, so that to get a right kind of eGFR. In children, that this CKD EPI epidemiological equation not utilized. We use device bedside Schwarz formula where the height as well as the serum creatinine is used to get the GFR. So this is a GFR that has to be calculated by this app, etc. So this app is freely available to be downloaded, and this can be utilized to make a diagnosis of change GFR in a patient where you are thinking of kidney disease. So when we are talking about the screening, particularly the diabetes being the commonest disease worldwide, the KDIGO, that is kidney disease improving global outcome statement, and the American Diabetes Association has said that patients who have diabetes, or we are trying to screen the kidney disease, it should be screened every year in patients who are having type 2 diabetes that we see commonly in adults, and every 5 years in type 1 diabetes. And the two screening tests that has always to be done is spot urine for urine albumin creatinine ratio, and eGFR that we talked about based on the serum creatinine, and sometimes cystatin C based on the calculator that we talked about, which comes from the app of KDIGO guidelines. It is said that when the report is positive, you need to recheck it one more time to see that it is consistently present. And if there are some kind of doubt about the creatinine value, then we need to check the serum cystatin C based GFR. The definition of chronic kidney disease in context of diabetes is that person should have a urine albumin creatinine ratio more than 30 milligram per gram. It should be persistent, and the EGF and or EGFR is below 60 ml per minute, and with or without other evidence of kidney damage in the form of ultrasound-based kidney asymmetrical size or scars or stones or cysts, etc. So two things are always a part of screening. One is the urine ACR, and another is EGFR. Urine ACR may not be the right test in the people who are not having a kind of glomerular disease, tubular disease, where we look at the urine microscopy to see the hematuria, uh, cast that is that a WBC cast or RBC cast. So albuminuria may not be the only test, but other tests of urine microscopy are equally important to complete the picture of kidney disease assessment. But for diabetic kidney disease or proteinuric kidney disease, these are two standard screening tests. So that was about the screening with the usual simple test that we talked about. But when you look at the syndrome-based screening and in our nephrological practice, that this is a kind of new concept which has evolved over time and recommended in 2023 by the American Heart Association, that we should combine the concepts of multidisciplinary team care for reducing mortality in such patients who are having a hidden kind of kidney disease, because the goal directed medical therapy will depend on the multidisciplinary care of this complicated patient. So earlier we were trying to classify a patient of kidney disease in case we made a diagnosis of CKD syndrome with CGA category. C means what is the cause of kidney disease, G is the what is the grade of GFR, and A is the albuminuria category. The metabolic syndrome was being talked about by general physician and or syndrome X, and which has a kind of risk factor associated with kidney and heart. And the cardiorenal syndrome, as a nephrologist and cardiologist, we used to make a diagnosis based on cardiorenal syndrome 1 to 6, or heart failure staging of near ABCD, or NEA, the New York Heart Association classification of heart failure with the symptoms of 1 to 4. So these were the syndromes where kidney disease was associated with, and all these syndromes have been combined to make a kind of clear cut therapeutically appropriate syndrome, a cardiorenal metabolic syndrome, or CKM syndrome, which will mean a multi clear for such patients. So this cardiovascular kidney metabolic syndrome has a different kind of screening recommendation that is said that person who is in stage zero, who is absolutely healthy, will, here the aim is to prevent the kidney disease by appropriate exercise and focusing such patients that they should remain healthy. Stage one is the cardiovascular kidney syndrome where you have excess fat, that the person is having a lot of fatty tissue, but no other disease. Stage two is a syndrome which was earlier called as metabolic syndrome, which is besides the fat, there is hypertension, hypertriglyceridemia, type 2 diabetes, or a kind of kidney disease which is present but which is not symptomatic, the stage 1 to 3. Stage 3 of cardio kidney metabolic syndrome is a syndrome of subclinical cardiovascular disease, where a person has a kind of subclinical atherosclerotic cardiovascular disease which can be picked up by calcium scoring of the coronaries, or subclinical heart failure which can be picked up by the echo as well as the NT-proBNP. And stage 4 is a syndrome where this is associated with symptomatic heart disease in the form of angina, myocardial infarction, atrial fibrillation, or the peripheral arterial disease or stroke. And these things are usually associated with advanced form of kidney disease. That is, any patient who is stage 4 or 5 of CKD is considered to be risk equivalent of subclinical cardiovascular disease. So this is basically a concept where we have tried to combine all the kind of risks which are seen commonly, which go together and which are to be treated together. So the screening for adults for based on the CKM stage is shown in the slide. The patient who is in stage zero but with a family history of kidney disease, it is said that you should look at the BMI and the waist circumference annually, and if appropriate, hemoglobin A1C should be checked every 3 to 5 years. But person who is stage one of CKM syndrome, it is whether patient is having excess adiposity. It is said that besides the recommendation for stage zero, we need to check more often the hemoglobin A1C every 2 to 3 years. In stage two of this CKM syndrome, it is said that we need to look at the liver risk, etc., by screening for liver fibrosis every 1 to 2 years, and you should start checking the usual screening tools that we talked about: kidney, the urine, ACR, and serum creatinine, and cystatin C annually, and consider the coronary artery calcification, heart failure screening, which may be appropriate in stage 3 of kidney disease, of CRM syndrome, where person has a subclinical cardiovascular disease. But this testing has to be done more frequently in stage 3, unlike in stage 2, where it is every year. It will be done maybe twice a year or thrice a year. And stage 4 disease, which is overt kind of cardiovascular disease, same thing to be done more frequently to get to the goal. It is as a patient stage 4 and stage in patient who have stage 4 or stage 5 kidney disease are equivalent to stage 3 of cardiovascular disease, and patients who have this kind of disease has to be overtly followed more frequently. So this is a kind of ISN-KDIGO algorithm for kidney disease that is usually followed the world over. That when you're looking at the population with the risk factors, or there are no risk factors. Risk factors are usually high blood pressure, diabetes, history of chronic kidney disease in the past or in the family, cardiovascular disease, or family history of kidney disease. If that is there, the test is already defined. But if there are no risk factors in the population, the no marker risk that we talked about, it is said that do not screen, and because it will increase the risk of the psychological distress in case some atypical or abnormal features come which may not have any clinical relevance. So the high risk population that we talked about, the hypertension, diabetes, history of kidney disease, cardiovascular disease, family history has to be screened by appropriate tests. The test that has been recommended is for the kidney is serum creatinine, cystatin C based kidney GFR. We can look at the urine examination for urine albumin creatinine ratio, and in the blood, the things that has to be checked is the blood glucose and anything which is the appropriate like electrolytes. In the family history, if there is any kind of family history of kidney disease, then the appropriate genetic test may be offered like a patient of polycystic kidney disease. Once we determine the patient has kidney disease based on GFR below 60 or presence of albuminuria more than 30 milligram per gram, then he is recommended to go for lifestyle modification, get the medical treatment, consider appropriate drugs for reducing the risk of chronic kidney disease and cardiovascular disease, and other considerations like drug dosing appropriate, contrast media use uh, to be avoided or not, that is to be looked at, and looking at hyperkalemia. And in case these things are not doing good, the patient has to be referred to a nephrologist. So this is basically an algorithm that the KDIGO has recommended, and they say that people who are not having any risk factors that we talked about, they should not be screened. So red flags for after screening for early referral is that when you find after screening the eGFR is below 30 ml, the person must be shown to a nephrologist. The rapid decline in GFR in a patient who is in the follow-up of a physician, if you calculate the GFR, it is only more than 5 ml per minute, that is called rapid decline. You should at least get a benefit of nephrological assistance in the care. Persistent hematuria in the urine without any overt urological cause needs to be referred to for evaluation of thin basement membrane disease or Alport syndrome, which can be treated appropriately to slow down the disease progression. And any person who is BP not getting control with two drugs, if, or three drugs when we call resistant hypertension, or any diabetic patient with any form of kidney involvement that is seen must be referred to a nephrologist. The disease process can be slowed down with appropriate multi-specialty care. The why an early referral is recommended is that once the patient is referred to the right specialist, he may be able to uh, counsel the patient appropriately to about diet and drugs, which can slow down the CKD progression. He will also focus on managing associated complications which may not look linked to kidney like anemia, bone disease, cardiovascular risk together. And early referral can prime the patient for the renal replacement therapy which may happen in case the kidney disease worsens over time, so that he doesn't get the shock of going to dialysis the first time without any knowledge that that was always there, but was never spoken to. Most people only think about avoiding dialysis in kidney disease once the diagnosis is made, but most people will not survive that long to reach an end stage kidney disease. And it was reported that particularly the older patient, they are more likely to die from heart or stroke related element than to progress to end stage renal failure. 5% of people above the age of 65 could reach this stage of dialysis, and 60% of patients died before they reach stage of dialysis because of the vascular complications. So, referring a patient, however, to a nephrologist when dialysis is required is akin to go for an antenatal checkup in a pregnant lady with liver, when liver pain starts, because the things have become very complicated. Patients may not be able to accept those kind of risks that is there, and ultimate longevity gets curtailed in patients who lands with the nephrologist when dialysis is required. So, in a day-to-day practice, when one needs to suspect that the patient requires a kind of checkup for kidney disease is shown in the slide. Then in children, clinical presentation could be in the form of growth retardation, resistant decay, or failure to thrive. In adults, this could be in the form of unexplained anemia when you have to think about kidney disease and difficult to control blood pressure. In a kind of high risk situation that we talked about, diabetes, hypertension, old age, ureteric obstruction, any vague symptom could be because of kidney disease. Any person who is having a kind of addiction like chronic smoking, alcohol, use of ecstasy drugs could be a kind of cause of concern for evaluation of kidney disease. If person has a family history of polycystic kidney disease and Alport's, This can be evaluated by appropriate genetic testing and other tests. In unexplained problems like when patients are getting investigated for infertility, sterility, recurrent potassium-related quadriparesis or weakness, this is also a kind of clue that this patient needs to be evaluated for kidney disease. And as we talked about, the high risk population is any elderly over the 60 years person who has a cardiovascular disease with recurrent hospitalization with heart failure, angina, recurrent UTI, diabetes of long duration that I talked about, family history of kidney disease, and nephrotoxic drug exposure. So these may be a clinical way to think that these are the patients who may be reporting to a doctor should be evaluated for kidney disease. The indication for referral to a nephrologist when the kidney disease has been diagnosed is shown in this slide. The general recommendation that when the GFR is below 30 ml per minute, which means a kind of creatinine of above 1.5 for females and above 2 for males, should be referred for an appropriate check. Any person who has a proteinuria of more than 300 milligram per gram in 24 hours, or including nephrotic syndrome, at least should be seen by a nephrologist to decide whether the treatment is going in the right direction. Hematuria of non-urological cause needs to be seen by nephrologist and not urologist alone. When there is uncertain diagnosis or a rapid deterioration of renal function, then it should be seen by a nephrologist. By rapid deterioration means the person has a kind of fall of GFR by more than 5 ml per minute per year, or there is a kind of decline of more than 30% of GFR after the use of drug therapy without any obvious explanation. Difficult to manage, particularly hypertension, hyperkalemia, recurrent stone, poor anemia correction, should also be referred to a nephrologist for the appropriate decision making. So the kidney is basically an epicenter for risk multiplication, and people with kidney disease are very uh, complicated because the abnormal pathophysiology and change milieu interior, they because of differential protein binding and drug interactions, the things many times cannot be uh, explained or cannot be predicted, and hence it's a complicated situation of biochemical disturbance where patients many times are getting complex prescription profile because patients have multiple symptoms, they're visiting multiple specialists and taking multiple consultation with a prescription which is multiple drugs with which may have a kind of drug related side effects which may not be understood because of the abnormal pathophysiology. Many patients of kidney disease are in it's always a constant psychological distress because they're following the lab numbers of EGFR and creatinine and getting worried about the future. And they're only afraid of dialysis. But the thing is that most of the patients, if not appropriately managed, will die before they reach dialysis. Only 10% of patients, particularly diabetics, reach a stage of dialysis, and 90% dies before that. But that may not be the case with those who are non-diabetic kidney disease, where sizable number may reach a stage of dialysis. So CKD therefore is a kind of risk multiplier, and in a broad situation, the prevalence of chronic kidney in India is around 15%. That is one out of 6 or 7 patients will be having kidney disease. In contrast, hypertension is prevalent in the population in the adult is around 30%. Then one out of three will have it. And diabetes is equally common, that is around 10%. The one out of 5 patients will have diabetes. So diabetes, kidney disease, and hypertension all are quite prevalent, and in combination they produce havoc if the person is having obesity, and hence the CRM syndrome. We have to evaluate the patient. What is shown in the slide that older patients 5% will reach end stage and 61% will die in 10 years in the study that was is quoted here, and that is basically because of the cardiovascular death because of increased atherosclerosis. So when we talk about kidney disease, we should not only look at the filters, which is going to fail over time in case we are not giving the gold dietary medical therapy, but it is always associated with disturbance of pump, that is the cardiac pump, and the pipes, that is the blood flow pipes, that is atherosclerotic alteration. So the pump, pipe, and filters, all of them in combination in kidney disease produces a kind of risk multiplication and death, and it has to be appropriately targeted. So in this context, on the World Kidney Day, we talked about that how. we can delay or avoid kidney failure. One has to remember that early CKD has no signs or symptoms. Chronic kidney disease can be treated. The earlier the treatment starts, the better it is, because CKD can progress to total kidney failure, but may not happen in all patients, and people may die before that because of cardiovascular complication. The way we delay the or avoid the kidney failure is that we need to keep the blood pressure below 140/90. We should maintain healthy weight and quit smoking in case that is being done. We should monitor and maintain blood sugar if one is diabetic. We should be active. We should visit the specialist, the heart and kidney specialist, regularly, and any other specialist if required. Medicine must be taken on time. Avoid self-medication and painkiller. Consult dietitian for customized diet plan, and that is how we can delay or avoid the kidney failure. What can one expect when the kidney is progressing is that the anemia can become a problem. Will require drugs like iron injections as well as erythropoietin or HIF factors, hyperkalemia or hyperphosphatemia, where we need to give potassium and phosphate binders, low calcium or low bicarbonate will require supplementation, increased risk of infection, which will require appropriate vaccination for preventing it, loss of appetite, which will require many times other drug supplements, and mental support for depression and fatigue, which is part of the disease, and lower quality of life. So these are things which has to be appropriately looked at when a patient is having a kidney failure. So once that diagnosis has been made, it is said that based on the albumin category and GFR category, patients needs to be called once, twice, three times, or four times a year for appropriate drug therapy. And that is the recommendation, that if the patient in green zone, at least once a year, a patient should come for follow-up once the diagnosis is made. And if people in red zone, they may require four times to come. That is, people who are having low GFR below stage 4 or stage 5 disease with albumin requires more close and more frequent follow-up. So the management pyramid for such patient who may have a kidney disease or who is likely to have a kidney disease is shown in this slide. That first important outcome that we look at the management pyramid is that the person should feel healthy and there should be a well-being. The feel good factor should be there, and so that is the most important goal in such care. Two important principles of such care is that care has to be patient-centered. That is, it may be individualized, and it should be in equitable care. That is, any person should have a similar kind of care, that a rich person or the poor person should get a kind of care which is similar. There should be no kind of dissimilarity. That is the goal. 3 point CKD health checkup, that is shown in the slide, that we need to check the blood pressure, which is an important kind of risk factor for kidney disease progression, and blood tests that we talked about, serum creatinine, electrolytes, hemoglobin, etc., and albuminuria, that is urine albumin creatinine ratio, and a CUE test in case there is hematuria, proteinuria, RBC, etc. The four pillars of therapy has to be always incorporated before we think about any other therapy. The RAS blockers of different types, SGLT2 inhibitors, non-steroidal MRA if appropriate, and GLP-1 analogs if the person is diabetic and obese. The five non-pharmacological measures that is a part of therapy is the appropriate nutrition, sleep adequately, stress management, exercise as is appropriate for age and the comorbidities, social networking that helps people to relieve their depression, and avoiding the substance abuse, that is smoking, drinking, and other kind of drugs like ecstasy. The six T's of effective patient clinical partnership is shown in the slide, that we need to talk to our patient, we need to do, do appropriate kind of follow up, we need to teach the patient, we need to have a kind of trust which develops over time with the patient, we need to do the blood checkup, and we need to call them for the follow up. The golden rules for healthier kidney that we talked about is to remain fit, we need to exercise, we must control our blood sugar and blood pressure, which are two important causes of kidney failure. keep the body weight in check and diet under control with appropriate kind of uh, restrictions. We need to reduce the salt intake and take an appropriate amount of fluid, 2 to 3 liters maximum. Uh, we should avoid smoking. We should not try to take the drugs on our own. They need particularly the analgesic drugs. And kidney checkup should be done frequently as per the need based on the doctor's recommendation. So that was all that we wish to talk about screening for good health for the kidney patients. Thank you.
Thank you so much, sir, for this
Yes.
wonderful presentation. We did receive few questions from our audience. If you'd like to take that up.
Yes.
So, sir, the first question is, which patient population should be considered high risk for chronic kidney disease and routinely screened in primary care?
Uh, as we talked about in the discussion, that the patients who needs to be routinely screened are people with diabetes, uncontrolled blood pressure, elderlies, people with family history of kidney disease, and people with rheumatological disorders where they are taking analysis for long time. So these are the general recommendation. Other things which needs to be screened are one in the childhood age group when the child is not growing well or has a bone deformity. So this may be general way to talk about that. Any abnormal kind of any patient who is getting evaluated for something very vague should also be screened. That is what I have said. Like many people are getting evaluated for sterility, infertility without any checkup of their kidney function anytime. Glucose checkup, thyroid checkup, everything is done. The kidney checkup not done till last. So that should not happen, etc. So any situation which is vague actually merits check for kidney, like we check for the sugar, we check for thyroid, we should check also for kidney function.
Thank you, sir. There's another question. What clinical markers or test result should prompt an early referral to an nephrologist?
Whenever a diagnosis of kidney disease is made based on the eGFR, which is cystatin or creatinine based GFR, or a urine abnormality in the form of albumin creatinine ratio abnormal, or sediment showing blood, pus cell, this at least should be seen once by the nephrologist to decide whether this is a nephrological problem totally to be treated by them or it should go back to general physician. So that is a recommendation. If you look at the cutoff is that every person with GFR below 30 or person who has a kind of very rapid kidney deterioration or person who has a kind of difficult to control blood pressure, difficult kind of electrolyte disturbance, person who is getting recurrent kind of paralysis, those things have to be definitely sent to the nephrologist.
Thank you, sir. There is one last question. How can primary care physician overcome common barriers to timely nephrology referral in high-risk patients?
Uh, in this complicated world of practice, many times people may feel that they will lose their patient when they refer to a nephrologist, but if there's a kind of trust factor, that may not happen. So, uh, ultimately, what is in the focus is the patient care, not the other thing around, etc. And it is recommended that the physicians should also keep on updating themselves uh, from the different sources of information which are correct information, not based totally go by the AI based tool, because that is the way people are trying to upgrade, but may not be the right way to have a complete comprehension of that. So to updating themselves to treat the patient and understand what is their limitation, because nobody is perfect in care, and patient referred late will have a kind of negative result that you talked about, that referring the patient when dialysis is required is referring when the patient has a particularly pregnant patient is having enough labor pain, you are sending for antenatal checkup. So it's too late, then benefits may not have seen. You have seen that people who come late for to nephrologist, they have a higher mortality compared to those who have been seen by nephrologist at least 3 months before they need dialysis. So that is a kind of thing which has to be based on your personal trust with the colleague that you see around. But the recommendation is that you should at least get a referral from this to the nephrologist when you have hematuria, proteinuria, uncontrolled blood pressure, uncontrolled kind of other situation like potassium disturbance repeatedly happening, hypotension, or complicated situation where anemia you're not able to correct, person is having anemia which you are giving therapy but is not getting corrected. So these are the areas which can be treated well by those who are dealing on a daily basis. So cutoff wise, GFR below 30, rapid change of the GFR by more than 5 ml per minute means urine output is less, swelling is increasing, and hypertension in general.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Sir,
Thank
before
you.
concluding, any take home message?
Take home, the take home message is that we need to screen the high risk population and refer the patient early to get the best result for the patient's well-being. We should not only think that we may lose the patient, because ultimately patient may lose life, and not only life, because the whole family gets ruined in case the patient develops an advanced form of CKD, and despite government support, it is a very costly affair. So we have to prevent it by giving the goal directed medical therapy, and we find that many times patients have never received throughout their lifespan the standard of care, that is we talked about the RAS blocker, then we talked about SGLT2 inhibitor, non-steroidal MRAs, GLP-1, sodium bicarbonate, anemia appropriate management, dietary advice, vaccination. These are things which are not in the focus of general physician, because many times when they are looking at big number of patients, these cannot get targeted. So it is very important to pick it up, send it to your friend who is a nephrologist, and see that the patient comes back to you, because it is basically a mutual kind of this thing. That's why people are talking about multidisciplinary care, the CRM syndrome. That is, no one specialty is perfect. To get the best goal, you need to interact and refer the goal directed therapy, which is already in the public domain, how to treat the patient.
Yeah, thank you, sir. Thank you so much. With this, I would like to conclude today's session and thank you so much, sir, for joining us today. It's a pleasure to have you here, sir. Thank you so much.
Thank you. Thank you.